or LA Live, sorry. And we're gonna now switch over to a video that Ken Chang has done on a TIF procedure, and he's gonna be talking to us live about the video and describing it. And then we'll go to some live in-room cases. So Ken, we wish you were here in the hotel with us. The food is delicious, but I'm sure you're doing great work out there. So, oh, good to see you. We can see you now.
All right, Tom, thank you so much. So it's quite poetic that my in-room virtual moderator is Professor Mufisami, who I had the privilege many, many years ago of, oh, I'm muted. Yvonne, am I muted?
No, you're on.
No, you're fine.
On, you're fine.
You're okay.
Okay. Who I had the privilege of being my advanced fellow many years ago, and I've been able to mentor him and now watch him grow, and now I'm getting mentored by him. So it's wonderful for us to come together for an occasion like this. So he's going to, I'm going to present the case, and he's going to keep me honest. Okay, so I'm going to share screen. Tom, can you see the LA Live on the screen?
We see the LA Live. We don't see you, but we see LA Live, and we see the UCI logos on the bottom.
Okay, I'm not sure, because I can see you guys on the Zoom, but that's okay. The more important is you can see the case. All right, I'm going to introduce the case, and we do have the ability, if there's a question, I can stop the feed and take questions as well. Okay, and then Rami can also.
Sounds good.
Okay, here we go.
A 64-year-old female with severe chest spasm and dysphagia on manometry showed distal esophageal spasm and hypertensive LES. A peroral endoscopic myotomy was performed on 4/23/19. Post-POEM, she has dramatic relief of spasm and dysphagia symptoms, but now she has GERD symptoms refractory to double-dose PPI and an acid exposure time of 17.8% with a DEMESA score of 63.1. So we now proceed to transoral incisionless fundoplication.
So we saw
on retroflex view, patient shows a Hill 1, possible early Hill 2 anatomy.
Okay, I like that the best. That's the widest swing. You get full scope back into the. So the TIF device is 60 French, and we place it under endoscopic guidance. So the scope is riding inside the device, and once we have it in place, then what we want to do is take the scope and pull it back into the device, and then the distal edge end of the device closes, and the scope goes back through a side channel, and then stays in a retroflex position. So right now we're going to transition from this position, which is the scope coming out of the tip, to the scope coming out of the side port. That's the best. That's the widest swing. You get full scope back into the device. Okay. So that's the transparent. Next will come gray. Next will come blue. Okay, right there. So once you're in the blue, I can open this up. So now the scope has gone through that side port, as you saw, and now we're looking at the working end of the procedure, more or less an over-the-shoulder look with the scope retroflexed behind the device. All right. So you lens. Okay. So this is 6 o'clock. That's 12 o'clock. This is anterior. The other side is posterior. So I superimposed this diagram for orientation. The 12 o'clock position is along the lesser curve of the stomach. The 6 o'clock position is right at the greater curve. Then 12, 1, 2, 3 is the anterior corner. 10, 11, 12 is the posterior corner. And these will become important as we navigate through the procedure itself. This procedure takes about 30, 35 minutes on average.
And Ken, will you always start in the same clock position?
Yes. So the one thing about this procedure is it's quite protocolized. There are many steps, but a lot of these steps are in sets, and these sets are repeated. So once you get the hang of the major steps, and then they tend to repeat and repeat and repeat. So we'll always start on the posterior side and do 3 plications. Then we'll swing to the anterior side and do 3 plications. Then we'll go to the greater curve side and place 4 plications. So that's 3, 3, and 4 equals 10. 10 plications is standard across every case. And then we put on a new cartridge, which gives us the opportunity to do another 10, but we don't always use all 10. And that's where we look for where there's a little bit of looseness, maybe place some in the mid valves. But the first 10 should be identical through all cases.
Yeah, and each of those
Thanks.
10 includes 2 fasteners, so you'll actually end up with 20, on that. And as you can see, for those of you who are uninitiated to this, it does require two endoscopists or two physicians. One, Dr. Chang, of course, is running the esophagus device, which is what you see on the screen, and then one person is providing the visuals through the scope, as you see there.
Yeah, the second person could be a second GI, could be a fellow, it could be a nurse, it could be a tech, it could be a surgeon. So it's not a difficult endoscopic skill. It's really keeping it in position, kind of like the laparoscopic viewing device. Just keep the angle of the viewing constant. All right, let's continue. Okay, so this is, keep following me. Is it okay if I walk through you? Yeah, not great. You can, but okay. So this is the posterior view. When you follow me, there's another way to look at the posterior view, and that is you go opposite. So I'm gonna stay here. You're gonna swing the other way. Swing. Now just rotate, and I'm gonna zoom in a little bit. Okay. So I just had Peter just swing over. Prior to this, the scope was behind where we are, and that angle was a little bit narrow. So I just had him swing over to this side, and you can see a beautiful view right into that posterior corner. The reason why we want to get a good view is now I'm going to place the helix and guide it into the lip of the tissue, again, around 11 o'clock, and rotate the helical retractor deep into the tissue to create an anchor. And it's from the anchor that we're going to pivot and do the retraction and wrapping. So I'm going to roll the video. That's nice and tight. Now, I'm going to swing this way. You're going to swing the other way, actually. Yep. Keep going. Okay, so meet me on the other side now. Okay, stop. Okay. And then you stop right there. Okay. So right now, the goal is to set the device, to bring the device back into the esophagus, and then to pull on this retractor. This helical retractor will then, that has engaged the tissue, will be tugging the tissue to create that intra-abdominal esophageal length as part of the new augmented flap valve. So this retractor can pull tissue down 3 to 4 centimeters, and that creates the length of the new flap valve. So I'm gonna, and then rotate out, yep, perfect. Okay, I'm gonna see if I can tug that down. So it's coming down decently. And this is that more, a little bit more, yep.
You mentioned patients with post-poem.
Yeah.
What percentage of your patients post-poem do you find are ending up with reflux? And is this your preferred method of managing that should it occur? Or
Yeah, great question. So we looked at our first 200 POEM patients, and it's a little bit different, the GERD rate for type 1, 2, and 3, but our type 2 POEMs, the patient, about 50% are on PPI, but only about 1.6% of patients after POEM are refractory PPI, meaning after double dose, they still have breakthrough symptoms. And that 1.6%, 100% of them can be taken care of with this procedure. So far, knock on wood, I've sent nobody to surgery to repair a post-POEM GERD. So that's roughly the numbers. So this is a great salvage because, first of all, if the patient had a hiatal hernia, which is unusual to have both achalasia and a hiatal hernia, but if they came in with achalasia and a hiatal hernia, I would have sent them to surgery right away anyway. So most of these folks don't have a hernia problem. They only have one problem. Their flat valve got cut by me. And so I can fix their flat valve with this, and it doesn't make their dysphagia worse because I'm creating length on the gastric side as opposed to tightening on the esophageal side.
Great explanation.
And we probably have about a minute or so left, okay?
Okay. Stay where you are. Okay, follow me a little bit. Okay, stop there. I want you to desufflate all the way, a little bit. Right there, stop. Okay. Stay there. All right, now I want you to swing the other way. Stay right there. And desufflate some more. Stay right there. Wait. Swing out a little bit. Okay. Push it on. Okay. So this is what I'm doing. As you saw, I pulled on the helix to create length, but in those corners, I need to do a 270 to 300 degree wrap. That is, I'm wrapping the stomach around the esophagus. And to do that, I'm rotating clockwise to get that gastric tissue around the back of the esophagus. Once I reach there, then I want to be able to attach all that. And that's when I do this little dance. I lock the helix so it doesn't loosen the tissue that I've captured. I lock the tissue mold, which then keeps everything held together. There's a suction that keeps the esophagus also attached to the device, so I can push the device beyond the diaphragm. And then I fire the fastener, and the fastener shoots out safely below the level of the diaphragm, and it couples the esophageal and gastric walls together in the place that I'm able to achieve that wrap. So that's the major step there. And now I want you to read the place. Go the other way. So that was just one plication, but with that one plication, you can see we created length and we wrapped. And so when you come back, we'll continue, but I essentially do that 3 times. And each time I go a little bit deeper with the wrap. I don't put the plications on top of each other. Each plication goes a little bit further into the wrap and a little bit more superficial to create that beautiful omega valve. And then later when you come back, we'll show you the anterior side, the greater curve side, and the final thing. So if this is a good time to transition either to Dr. Samarasena's live case or to Dr. Sedarat's poem case.
Great, thanks, Ken, appreciate it. So why don't we switch over to our live case that we have now? All right, I think we're connecting. I'm not sure if we're connecting to Dr. Sedarat or. Oh, okay, Jason, we can hear you and see you now, or we can see you.
Perfect. Okay. Can you hear me now?
Now we can hear you, yes.
Okay, wonderful. If it's okay, I'd just like to give you a quick follow-up on the last case that we had in this room. It was our patient with Barrett's esophagus with high dysplasia. And there was a fairly sizable nodule, and we were debating whether we should do an ESD or or an EMR. And so we'll see if we can switch over to. Are you seeing the? Actually, we're just gonna switch
No,
over.
we're
to
just seeing you, Jason. We're not
Okay,
seeing any embedded video.
See if we can switch over to the presentation. John,
Okay,
thank
now
you.
we're on a blank screen. Now we see your video.
Okay, great. No, so these are just a couple images. So basically, this was a nodule, and measuring it, it ended up being about 2 centimeters in length, sort of endoscopically. So we felt, just in case there is a bit of cancer here, it might be best to do an ESD. And so go ahead. And so basically, we removed the specimen. It ended up being about a couple of centimeters, and then you can go to the next one. And that's how it looked afterwards. And so it was and the only downside of the ESD for me was I got to miss the corner bakery lunch that these guys enjoyed on the 3rd floor while I slaved away on this ESD. But I think the patient's very happy. We told him that we removed everything in one piece, and I had the discussion with him that this might be a possibility to do an ESD. But again, I think with the knives here now, and with the skill set developing, I think we can pull the trigger on these ESDs a little bit easier. And I think in this case, it was probably the right choice. We'll see what the pathology shows.
It was worth missing your lunch.
Yeah. So, but Yvonne apparently saved some lunch for me. So thank you, Yvonne. All right. So we're going to move on to the second case here. This is going to be an esophageal stricture case, and Dr. Kim here is going to present.
All right, thanks. So this is a 43-year-old who's had longstanding history of dysphagia, primarily to solid food, and he pretty much managed it with dietary restrictions. Never had a prior EGD before. Up until March of this past year, he was hospitalized at another hospital, had an acute food impaction. They tried doing an upper endoscopy at that time, but there was a proximal esophageal stricture that they weren't able to traverse. So the patient was ended up transferring to UCI. We repeated the EGD on March 17th, and around 18 centimeters, there was a tight stricture. Not even the XP scope could pass through this area. So the area was dilated with balloon from up to 12 millimeters. Eventually, the XP, even so, the XP scope actually could not pass. So the patient ended up having a stricturoplasty with needle knife. Then the XP scope was able to pass. There was actually a long linear mucosal tear, which we were suspecting that it was related to the food impaction, but there was no extravasation that was seen. There was also mucosal changes that were consistent or suggestive of EOE with linear furrows and rings, and the pathology kind of confirmed EOE with up to 35 eosinophils per high power field. Patient followed up with us in early April. At that time, dysphagia had actually improved. He was tolerating a liquid diet, which we was instructed to remain on. After that dilation, he had some heartburn, started on Prevacid 15 milligrams twice a day with adequate control, and then also started on topical fluticasone. And then plan was for a repeat EGD. Patient ended up having the repeat EGD done a couple of weeks later on April 30th. Again, at 18 centimeters, was a stricture that couldn't be passed with the gastroscope, but the XP scope was able to pass through it. Distal esophageal mucosa at that time looked normal, and then the stricture was dilated to 11 millimeters. And that brings us to now, patient was instructed to remain on PPI twice a day, remain on swallowed fluticasone. And so I don't know that do we have another slide? No. Okay, that's it.
Okay, great. And Dan's going to pass the mic over to my moderator, in-room moderator, Dr. Adarsh Thakur. And okay, you can see Adarsh there. So, it's a pretty incredible story if you talk to this gentleman. He lives pretty far away up in Mammoth Lakes, and he said like his entire adult life he's just struggled with food. He's sort of this closet eater. He goes to restaurants and he literally cuts food up, puts it into his pocket, to avoid the embarrassment. And he had, no idea that he had this condition called eosinophilic esophagitis. So, even with these last couple of dilations, he said, wow, my life has completely changed. Like, I'm not as afraid to eat food. And, the things he was telling me were surprising. He's like, this has been a game changer. And I thought, when we kind of look today, it's going to be wide open. It's going to be, he says he's eating meatloaf. He's eating like potatoes and pasta and like, he had some short ribs the other day. It kind of like totally blew his mind, And so, but if you look, to me, it doesn't look like we've made a whole lot of progress with the stricture. The other thing that I was curious about his case was the strictures up here, but he had, and I should have put it in the presentation, this enormous 9 centimeter tear that was almost full thickness from 30 to 39 centimeters from the incisors. So that was sort of kind of curious, like why did he have a huge tear there? And I wonder if the esophagus just was peristalsing so much that you know it caused that. But we were really fearful that he actually had a full thickness perforation, but the contrast study looked okay. So the question now is, we've got a patient who's got a proximal stricture, who seems to be doing relatively well, much better than, a much bigger improvement. But, we can't get our regular EGD scope through. I would say this is probably still about like, 6 or 7 millimeters in diameter. And so, he definitely would love to get to the point where he could eat more reliably, more comfortably, and safer. And so, so the question now is, what do we do with the stricture? I don't know if anybody has any thoughts.
I think even if, let's say he was doing fine, I think it's looking at this, it's only a matter of time before he's going to be back with another food impaction. I mean, this is already small.
I totally agree. Yeah. And so, I think one of the things that we've been doing a lot more of is sort of incisional therapy. Some people are using, ESD knives for this. I know Dr. Chang is a big proponent of this as well. And he uses the IT knife with an insulated tip. He feels that's very safe. I think the classic approach for this has been with needle knife, and I think needle knife works very, very well. I think this is almost looking a little like a ring, and not, and so I think these are sort of ideal. And I think with rings, especially, if we can kind of score the mucosa, in multiple points of the clock face, then when you do your radial force from the balloon, it's going to tear in multiple locations. And I think the chance of recurrence is going to be less. When you just balloon dilate, typically the weakest point in the ring will break open, and then it will sort of scar in back at that point, and the ring will recur. So I think if by doing this, you're kind of traumatizing the ring at multiple places. And I think for all those places to recur, it's going to be a lot more difficult. So so that's what I was thinking about doing today, is using needle knife to kind of open this up a little bit and then do a balloon dilation.
What's your burden of checking out the other side first? Now, in this patient, you've already been there, but let's say you're coming upon this, you may be the first person, maybe before his food impaction. How obligated are you to kind of go and see the other side, maybe with an XP scope, but maybe even that won't fit? Here you can kind of see down a little bit. It looks like you kind of know what's there. You've been there before, but what are your thoughts on that?
There's a great point. Yeah. And I think in this case, I think it's always a good idea to look, and if you can even do it, just a small pre-dilation, just so you can get an XP down, so you can understand, what's coming next. Because a lot of times, especially with EOE patients, you may be dealing with, this might be the tip of the iceberg, and there may be multifocal strictures going, further, and sort of understanding that is really important. And if you can't get there with an XP scope, well then, we've all got lead on, we're in a fluoro room. All of my dilations I'm doing with fluoroscopy for a couple of reasons. One is, when I'm dilating with a balloon, you never know without fluoro how big the balloon goes up. You'll have your assistant tell you, we're at 2 ATMs, which is 13 millimeters, but you have no idea what's happening at the level of the stricture unless you use fluoroscopy. And, we've had so many times where we're looking at the fluoro, and he's telling me it's at 13 millimeters, and the waist is literally at 5 millimeters,
right.
And so, so I think that's the advantage, and hopefully we can show a little bit of that today.
Some good feedback real time from the fluoro image of how wide your balloon is.
No, I think it makes a huge difference because, and I think, from the safety standpoint, I think it's better because if I see that waist, it's really, really tight, and then I see it open up, I will like pull back on the balloon very, very quickly to make sure I don't have complete effacement of that balloon.
Right.
Because I think if you don't see complete effacement and you always see a waist, I think the chances of, that esophagus perforating is extremely low.
Okay.
Yep. And okay. So, but then the other nice thing with fluoroscopy, I feel, is that you can do like the most therapy in one session. as well. You get the most bang for your buck with the fluoro also. So let's have a look here. So okay, great. Okay, so we'll get needle out. Okay, perfect. So with this particular technique, what I like to do, and let's see if we can. So sometimes having the cap is nice because you can kind of create a more of a ledge. So I see sort of my first ledge here. Mike, can you hold scope for me? Thanks. Perfect. So I'm going to actually look it right there. And then move to the, thanks. Move to the inside. And I'm just sort of going outside in to the lumen. So I think it's very safe to do it this way.
I like that outside in because you kind of know where your outer point is by looking at where the esophagus is above and below. You know, you're kind of your outer margin. So if you're going from inside out, you might go maybe a little too far. Something slips, pops you over. It's a good idea. Question becomes when to stop cutting, but this way you are starting at your endpoint really and coming in.
And so, and again, you know, this is really kind of like the score of the tissue so that you can, you know, go in there and open it up with the balloon after, or mechanical dissection just with the scope itself.
Jason, for something like this, or maybe on the previous ones, would you inject Kenalog or consider doing that to try to reduce the risk of stricture formation in the future?
Darsh, what are your feelings on Kenalog?
I think it can be helpful, especially after if I have someone that I've dilated a few times or done some kind of treatment, maybe 1 or 2 sessions, and they're scarring back down quite quickly. I might try 1 or 2 sessions with Kenalog. There is some data to suggest that it can be helpful, but then there's also data suggesting that it can increase risk of Candida and other things, or that it doesn't work. So I typically don't do it right from the start, but if someone looks like I might be losing the battle from the start, I'll typically do it. And my practice, I think, is consistent with others, where I'll take about 2 cc's, 40 milligrams, and do half milliliter injections. I've seen it done both ways, where you'll inject first and then do the dilation or cut, or you'll do the dilation and then inject it kind of where those tears were. As Jason was kind of talking about, sometimes you get an asymmetrical, one side is where your mucosal tear is. And so maybe if you inject the Kenalog there, it can prevent the rescarring. I don't know what your practice is, but that's typically how I approach it.
Yeah, I totally agree. I think Kenalog, definitely, it's interesting. If you look at the data on Kenalog, it's like, a comparative trial with like 32 patients, and it was like, on peptic strictures, and the data on strictures is very, very limited because it's hard to do these comparative trials, and so I think, but yeah, I've definitely had some success stories that I can definitely attribute to the use of Kenalog. So
I think you made a good point about dilation in general. When you think about where the force is distributed, I've talked to Alireza Sedarat about this, how when you're doing a dilation, you're really going to be breaking out what the weak point is. It's not a truly evenly distributed radial force. You kind of, the tear starts at the weak point, and then that point becomes even weaker as you continue to dilate. And so you do have to be mindful of that with certain shape strictures. I often think about this when we're asked to do some kind of dilation or stenting in tumors, whether it's in the esophagus or in the small bowel, where that stent or whatever it is not going to open up evenly with equal force on all sides. There may be a weak point that starts tearing open a little more. So just something philosophically to keep in mind, I think is a good point you made.
No, I totally agree. So you can see now we're actually doing a little bit of mechanical dissection in the process of doing this this incisional therapy, and honestly, sometimes after this is done, and this is sort of kind of the goal, right? I mean, you do a dilation to see rents that look like this, but now these rents are extremely, kind of precise, you could say, because we're making them with the needle knife. So I think it's and again, you're seeing this ESD cap sort of create these shelves that may not be there if you don't use an ESD cap. And so so we're making our way here through, and so the hope is eventually we'll kind of get through, and I may end up finishing this with a little balloon dilation, but it's coming along.
Yeah, looks very nice so far.
Great. This is awesome. We may be switching over to Ali for a sec here, okay?
Okay, thank you so much.
Okay, thanks, Jason.
Okay, you bet.
Okay, Ali, we are in the process of switching to you. I don't think we have you yet.
This one? Okay. Can you hear us, Dr. Savides?
We see both of you, yes.
Okay, perfect. I'm going to share just a quick presentation. Can you see that screen?
Absolutely, absolutely.
Okay. So we're going to be presenting, I have Dr. Chang here to tell me what I did wrong, what I could do better next time. So we're going to talk about a patient with achalasia that we did a poem for relatively recently. So this is a 65-year-old with dysphagia, not too much in terms of medical history, long-standing esophageal symptoms, and has this somewhat typical story that she was just told she had reflux a long time ago, but she didn't really get responsive to PPI, which I think is an important, historical point, that most typical reflux folks, their symptoms should really get fairly better with PPI. And if they don't, they deserve investigation. So anyway, she progressed to have more dysphagia type symptoms, which progressed, and she got evaluation. The score here is her Eckhart score, which is a composite score of dysphagia-related symptoms, including weight loss, dysphagia, external pain, and regurgitation. And she was having pretty severe, frequent symptoms that were getting worse. So her score was 7, which is a pretty good score. Generally, in studies, you're looking for things to get an Eckhart score of less than 2 to indicate response. So the esophagram, a caveat, is not hers. It was an outside hospital esophagram, but this is representative of what a typical achalasia esophagram looks like, dilated with a typical bird's beak at the bottom and a trickle of contrast into the esophagus. And this is what a typical endoscopic view of the LES would look like, or just above the GE junction, a type rosette of spasm with some lumen obliteration and blanching with pressure. She had, which is also somewhat typical, just an empiric dilation. In this case, it was a bougie type dilation. And she got a little bit better for a week, but typically achalasia patients with either CRE or savory dilations, if they get improved, it'll be relatively short lasting. This is the manometry, pretty typical of type 2 achalasia. This is one of those things you can see from, across the room. Here's the upper esophageal sphincter. Here's the lower esophageal sphincter. Whenever I look at one of these, I always hear Dr. Conklin behind me interpreting it for me. And every time I look at one, I hear his voice, which gives me great pleasure and pride. But so here's the swallow with the UES relaxing. You can see there's no peristalsis. The LES maintains pressure, it incompletely relaxes, and there's pressurization in the esophageal body. So that all of these are composite findings of type 2 achalasia. And so here's the immediate pre-poem EndoFLIP. This will be a caveat that it's not exactly this patient's EndoFLIP, but it is a type 2 patient before and after. Dr. Chang, tell us what we're looking at.
Yeah, so this is a mapping of the pressures at 1 centimeter segments. Right in the middle of the waist, we can see the diameter is 5 millimeters, 5.0. And then over on the right, you see the distensibility with in red 1.0 millimeters squared over millimeters of mercury. So the distensibility index is the most important parameter to diagnose achalasia. So a DI of 1 is very significant, high pressure, going along with achalasia. So normal DI is 3 and above. Achalasia patients can have DIs from 0.5 to up to 2.5, but typically we see them in the 1 range.
Very good. Does so besides the DI, do you look at the diameter, or is the DI really the most important one to you?
The two of them together.
Together.
Yeah.
And then what about the volume of the bag and the balloon pressure? What does that tell you?
Yeah. So the volume in the balloon. So here we have 30 mLs. So all the studies from Northwestern where this originated look at the volume of 40, 50, and 60 to be the most important. And you can also gauge it on the pressure in the balloon. Right now, the pressure in the balloon is 20, which is okay, borderline okay. You want the pressure in the balloon to be in the 20s, because if the pressure in the balloon was 12, that means there's only partial filling and you're not getting an accurate pressure reading. So we usually take the 60 ml as the most reliable number that we follow over time.
Excellent tip. Okay, so I'm going to stop this sharing, and we'll go to the video. And oops, I should share it first. Okay, and so hopefully you can see the video now.
Oh, yep, we can see it.
You do? Okay, great. So it's edited for time. This was just after the injection, and you see we can start the mucosal incision. We've edited out some instrument exchanges and some dead space. And you can see that we've started our injection. This is a type 2 achalasia patient. And correct me if I'm wrong, Dr. Chang, but I think we're trending towards slightly shorter myotomies than maybe we did 2, 3, 4 years ago. What do you think?
Yeah, the standard surgical was 8 centimeters in the esophagus, 3 centimeters in the stomach, 11 total. And we're finding that's way overkill. So now the trend is more like 6 centimeters in the esophagus and 1.5, max 2 in the stomach.
Oh, interesting. Yeah, so I think we've come up into the esophageal body probably less than 10 centimeters, probably even less than what you quoted there to start. And we're doing a posterior tunnel, which you could do posterior or anterior. There's kind of pluses and minuses to either. It seems a lot of folks start anterior and then kind of migrate to posterior as their experience increases. I find that the anterior approach, the entry is a little bit easier into the tunnel because gravity tends to open the flap. If there's bleeding, like you saw there, it tends to pull away. So that makes it a little easier. The dissection, it's probably about the same. Sometimes the anterior is easier, sometimes the posterior is easier, depending on the tortuosity. The myotomy, though, is definitely easier on the posterior side. So you can see as we've sort of trimmed away vertically coming down, and you can see a little bit of bleeding, some of those superficial veins in the esophagus got cut, and so the submucosa here is a little dirty. But now we've kind of started cooking a little bit as we've identified the plane. And the plane of dissection, to me,
Ali,
is right on top of the muscle.
quick question, Ali. I mean, I'm seeing you're using a different device than Ken was using to create the tunnel. Looks like you're using a triangle tip and Ken was using a hybrid knife. Can you comment if we're seeing that correctly, and what are the differences?
Yeah, that's correct. This is a triangle tip knife. It's a triangle tip knife with a jet function through the catheter, as opposed to through the tip of the knife. So it does have an injection function. It's a matter of preference, whatever kind of you like and what you learned on it. I've used both. I think both are totally valid. I prefer the triangle tip because I think it's better at the myotomy. It hooks just a little bit better in my hands, but certainly whatever you're used to. And, if you're bored with one, just try the other for fun. That's no problem.
Ali, I see this huge vessel there. I'm just curious to see how you're going to handle that.
Yeah, carefully.
Yeah, there's at least an artery there.
Yep, or I think it's a bundle.
Bundle, 2 veins and maybe 2 arteries. So do you switch to a coag grasper, or you just keep using the the TT knife?
Yeah, we're gonna switch. Perfect.
Okay.
You would think that was rehearsed, but it wasn't. Perfect. So I think this is just at that borderline size that you may be able to, with adjustment of your electrosurgical settings, coagulate through that vessel without too much trouble. The problem is that if you guess wrong, or if you coagulate too much, or too quickly, I should say, and if you have bleeding, your tunnel becomes very dirty, like you saw initially, and then it really slows down your dissection. So for me, it's a little bit of a feel whether you use the knife. I often use as you know, the forced coagulation 110 setting, which is very gentle, slow cook. In this case, it's soft coagulation. And so, you know, it's the time of the instrument exchange versus the time of dealing with bleeding. You just kind of make a judgment. Certainly early in practice, you would use the coag grasper, you know, much more freely, I would think. And then as you get more comfortable with how your knife behaves, you can, you know, use it more freely for hemostasis. So we're kind of, you know, going along here, the dissection plane right on top of the muscle. Unlike an ESD, buzzing the muscle here is not only acceptable, it's desirable, because it tells you that you're far away from the mucosa and you're going to cut this layer anyway. So you don't have to worry about coagulation of it. It keeps me honest. It helps you visualize the layer. The most important clue to me is the orientation of the muscle fibers, and staying perpendicular to those muscle fibers really keeps you on target. Which becomes sometimes significant in a very tortuous esophagus. This one here, I think we're probably hedging. Do we want to cut it, or do we want to buzz it? We may be adjusting our settings perhaps to decide. And it looks like we went through it a little too fast, so it's probably gonna bleed shortly. You'll see, I think. And one of the things about dissection is that your settings and your knife are secondary to your technique. So with the same exact setting, with the same exact knife, allowing the coagulation to do the work, it probably would have cooked faster. And in a second, you'll see it's gonna ooze a little bit, and we have to control it.
Now, is this precise like a force coag?
This is spray.
Spray. Oh,
Yeah, I'm pretty old school with it.
Okay.
So this thing, you can see it started to. So the settings, for those that are interested, the incision was endocut Q, effect 2. My dissection is spray, effect 2, 40 watts. My coag is effect 5, 80 watts. I have done poems with the precise cut effect, and it's nice. It actually works really well. I think it's good at both hemostasis and dissection. It takes a little getting used to, because the spray is almost like a non-contact. It's almost like APC in a way sometimes. So if you're used to that feel of barely having to touch anything and it just vaporizes submucosa, it takes some getting used to. So in the interest of time, I might fast forward a little bit we're starting to get to the area where you can see the real money dissection happens, right? It's easy to do the esophageal body. Things really slow right around here, don't you think? Yeah. This is where the complications tend to happen of mucosotomies, because you're in a closed space. If you hit a vessel and you need to coagulate, you can very easily injure the overlying mucosal layer. To reorient you, the muscle is at 6 o'clock, the blue submucosa in the middle, and the back of the mucosa is towards the 12 o'clock.
So what's your strategy? You're in that tight G junction. The LES is really bulky. What are your strategies?
Yeah, I mean, one is to just constantly re-inject and reorient. I think you have to be careful pushing through. And in fact, in this situation, I'm going to come back. I know I'm not far enough. I'm going to come back, start the myotomy, release some of the LES fibers so that I can comfortably and safely extend that couple centimeters into the cardia. You can push the problem, and probably the LES will accommodate. but potentially the weak point may be mucosa.
Mhm.
And as you push, and so you're just kind of feeling it here,
Mm.
you know, it's like, it kind of feels tight. It doesn't want to admit me. Maybe I'll try opening the space,
Mhm.
but ultimately you'll make the decision. You'll see to kind of go back up. So if you risk, if you push, that you essentially do like a dilation injury to the mucosa,
Mhm.
which is perhaps of no consequence. You could, you know, just go and clip that, but it's just an extra, you know, headache that you can easily avoid. And so you can appreciate, though, those muscle fibers really impinging the passage of the scope. So we'll fast forward a little bit so you can see the start of the myotomy right about here.
Circular only, full thickness from the get-go?
I definitely start circular only and almost always maintain selective circular all the way through for a couple of reasons. One is it keeps the procedure intramural,
Right.
so that should you be inadvertently adjacent to something like the vagus or a larger extramural blood vessel, your risk of injury is essentially zero. I think it really eliminates your gas-related complications. So those are relatively easy to manage with abdominal needle decompression. We haven't had to do that in a long, long time. And I don't think you get much from a full thickness myotomy compared to a selective one. The data hasn't panned out too much that it makes much of a difference in terms of reflux, in terms of efficacy. I think that might be partially a heterogeneity of older data. There's a suggestion that anterior versus posterior is different with reflux outcome. I think we're going to learn is that the devil's in the details as to whether your full thickness includes sling fibers on the posterior wall or not, and finding out that microanatomy. And so doing the selective circular myotomy, particularly posteriorly, allows me, I think, to preserve the collared sling muscle fibers. And so I try to. That being said, sometimes it's very hard to maintain it. Sometimes it's very
so wispy,
thin, very wispy. Sometimes you can't tell, and I'd rather do a complete myotomy and make it full thickness than try to be, you know, cute and make sure it's only selectively circular.
So, but when you get to the LES, are you full thickness or are you?
I maintain it through just circular.
All the way through.
Yeah, unless I'm forced. If it doesn't, if it won't let me, I won't kind of kill myself to be, you know, only. If someone has had a failed Heller or a failed poem that comes to me, I'll probably be a little more likely to just cut everything, just because it's, you know, almost your last shot, if you like, type of a thing. So what we'll do is, just in the interest of time, you know, fast forward a little bit.
And Ali and Ken, one question that came up, it's, you know, imaging is obviously critical here. So can you just talk a little bit about, you're using near focus? Are you using, we don't see you use any blue light imaging or any other types of enhanced imaging, but can you tell us what you prefer and you know, how to even make imaging a little better if you need to?
Sure. Yeah. I mean, I think a high definition scope with high definition monitors is super critical. You really want to be able to see tiny details. NBI or other colored stuff doesn't matter to me too much. Near focus, though, I do think helps at different phases. And if you look in the upper right corner, you'll see me kind of flopping back and forth. Sometimes it's really hard, you know, if there's a lot of fibrosis or the muscle fibers are crossing, trying to figure out the microanatomy. I think near focus really helps. I have a very low threshold for taking the scope out and cleaning the lens. Often, you know, do that several times during a case. One of the downsides of spray coagulation is you can get some additional junk on your lens. But, you know, it's the esophagus. It's very easy to come out and go back in. Yeah, what do you think?
Yeah, I agree. But the thinnest scope with high definition is the 190, not the Q. So I choose that because it's a slimmer scope, easier to get to the tunnel, but I do lose the, you know, the near field, which is okay. So that's the trade-off.
Here we're seeing a important anatomic structure that we're going to start to dissect. The so-called Tanaka vessels, or the two penetrating vessels on the posterior wall. You'll see them shortly as the submucosa extends. There's a paired set of them, one at the start of the high pressure zone and one that is basically at the bottom of the LES complex where the collared sling fibers come across. So you'll see them right there at the left of the knife. I'm trying to avoid cutting them. And if we stay towards the lesser curvature side of that, we can, meaning to the right of the screen, we can avoid cutting the collared sling muscles. And correct me if I'm wrong, Ken, but that is thought to translate into less risk of reflux.
Yeah. So there's a really important initiative to make our POEM procedures as anti-reflux as possible, not after the fact, but as we're doing it. So one of the key strategies is to, when we're doing the myotomy on the stomach side, not to sacrifice those very important sling fibers, which we're just beginning to understand in terms of our GERD knowledge, that those sling fibers are super important on the gastric side of the LES construct. So the least population of those sling fibers is at 12 o'clock at the lesser curve. So this method of identifying those two vessels is a very good one. The other method which we employ is, prior to doing any of the tunneling, I go into the G junction and I put some submucosal injection right at 12 o'clock. And I call that a navigational tunnel, because then when I come back through the tunnel, I'm going to land in that blue. And then I know. Now, these vessels are good, but I don't think they're 100%. I call them the welcome to the cardia vessels. So when I see them, that's my welcome to the cardia, and I go to the right. But if we do the injection, then I just follow the blue all the way down, and I know I'm way up in the lesser curve.
Very good. That's a good tip for sure. Yeah, sometimes it's not straightforward at the cardia, particularly if there's been other interventions. They have a little hiatal hernia, perhaps. Sometimes it's easy to get disoriented. So we're coming towards the end of the tunnel. There's a couple of free circular fibers that we're going to touch up shortly, but you saw before we were measuring with the catheter that it's just about 2.5 centimeters. I think anything between 2 to 3 centimeters is ideal. Anything more than 3 centimeters, clearly you don't get any bang for your buck and it's more reflux. Anything less than 1.5 centimeters, you're probably not in an adequate cardiomyotomy situation.
How are you confirming depth of your tunnel?
Yeah, I do double scope transillumination. I don't think we put it in, we may have in this video.
Okay.
But I do it for almost every case. I think it's probably the most reliable way to know that you've crossed into the cardia. Most of the time you can tell based on your high pressure zone and length and the change of the vascular submucosal anatomy, the spindle veins and things like this. But it's definitely a very good confirmation. And I would say perhaps 1 to 2 in 10 of cases, it's made me extend a centimeter, and made me happy that I did it. So I think it's a worthwhile step.
Yeah.
What that is, and perhaps we'll just kind of fast forward so y'all can see that, is putting the main scope into the tunnel. By the way, you can see now that after the myotomy, the LES is fairly open. So we have the retroflex view. You can see a little bit of a gap between the scope, not too much, which I guess is good. And it's certainly not gripping the scope like it was before. So now we have the main scope in the tunnel. These, by the way, are the spindle veins that folks talk about, these little bugs crawling in the submucosa. That's a good marker of the cardia. And we're going to put a baby scope. You can put the baby scope in whichever side. I tend to just leave the mother scope in the main tunnel and then put the baby scope in the. And so now you see the light there, and it's shined on the cardia side. It always was kind of tricky to me to know exactly, should you look for space between the light and the scope? Do you have to measure scope thickness? I think I just want to see that the light is below the squamous junction, because I think sometimes depending on how you're angling the light, you may be off by 1 centimeter or 2. What do you think, Ken? Do you have to?
I think that's the most important thing, that you can see the light on your retroflex view, and that it is in the proximity of that lesser curve. Sometimes I'll get more OCD and want it to be about 1 centimeter below, but I don't think that's really important.
Yeah. A combination. I think the point of it is that the combination of all these factors when you put them together, makes you confident. So at the end here, we have a good, 6 or 7 centimeter myotomy. It's relatively short, but it does the job. Crosses, and I think we'll get a nice loose view of the LES there.
Very loose.
And for the interest of time, we'll just kind of fast forward to our closure.
So Ali, what do you do with patients who, on manometry, they're type 2? But the patient will tell you, I swear I have terrible spasms all the time, every day.
Yeah.
So do you treat them like a 2 or do you treat them like a semi-3?
Yeah, that is a great and difficult question. I treat them like a semi-3. I lengthen their myotomy. Instead of doing ultra short like this, I'll give them like our old school 10 to 12 centimeter, maybe esophageal myotomy. The other thing is, I think in some of those patients, 2 categories. One is if you look at their esophagus, you'll actually see some degree of contractions that the manometry just didn't pick up. And I wonder if the long balloon EndoFLIP may start to pick some of those patients up objectively. That said, I've had some patients who post-POEM have had persistent chest pain that has responded and has no spasm on manometry, that have responded to TCAs, tricyclics and their chest. So I think there is a neuropathic functional component that we have to recognize as well.
Yeah, I'm really careful about when the patient gives me a history of spasm, even though the manometry doesn't say type 3, I look at the time barium to see if there's any spasm. During endoscopy, if I see any spasm, I always do an EndoFLIP pre and post to see if there's spastic segment. And I'm really anal, so I also do an EUS before POEM, looking at where the transition of the thick muscle is. And based on all of those, I will cut as high as I think is necessary, because I've had a couple of cases early on where I didn't do that. And the patient said, well, the fluid's going down, but my spasm is killing me. And then I went and extended the myotomy proximally, and that took care of it.
Did better.
So
so here's we're just pause this share.
Ali and Ken, just a quick time check. We got a couple more minutes, and I didn't know if we needed to go back to Jason or if we're just finishing up with you. So I'm going to defer to the.
All yours. This is for demonstration purposes, just the post-POEM EndoFLIP, and then we're done. Go ahead, Ken. What do you think?
Yeah.
Looks open.
Looks really open. It's all blue.
Yeah. Perhaps the pressure in the balloon, maybe we should have waited for it to get bigger. But it's only at 15.
Yeah,
13.
it's only 15, but that's fine.
It's still even under those low pressures opening up. So what's too big? What's too small? What's the cutoff?
Yeah. So I like it when the DI goes up into the 3, 4, 5 range. I don't like it when the DI goes like 8, 9, 10, and the diameter goes to 12, 13.
And then you think someone may get reflux.
Yeah.
Okay. So that sweet spot to you somewhere between what, 4 to 6?
Yep.
Great.
What do you think?
Yeah, that's about right. No, we don't have as much experience with it. And I think the data is really good for dysphagia relief.
Right.
I'm not sure it has panned out as much for reflux, TBD. I think we're going to go back to Jason now. Is that right, guys?
Yes, we're going to go to Jason. Great case. Thanks for showing that, Ali.
Great, thank you. Appreciate you joining.
We can switch to Jason. We can see you now.
Okay, Tom, welcome back. So, great demonstration, Ali, and great discussion. And so we've been not quite as busy, but we got through that first stricture, and there were 2 more. And we basically, continued with the same technique. So let me come back up to the top here, and so I've got a 12.4 millimeter ESD cap on, and now this was the first area that you saw us using the needle knife therapy on, and now we're kind of easily able to kind of get through. This was the second area that we encountered that was narrowed, and we basically did the same thing. And now coming down, this all looks okay. And there's a little bit of resistance here, and we did a little bit of needle knife here as well. So, not unexpected to have multifocal strictures with eosinophilic esophagitis. And not sure if you can still see us, but one of the things that I like to do is a kind of a balloon sounding technique where we get a balloon down and see if there's resistance with pulling back the balloon. And so go ahead. You can inflate. Why don't we go to 13.5?
Sounds like they could still see us.
Okay, perfect.
And one thing while you guys are dilating, one thing that I noticed here, I was imagining if we had just done balloon dilations from the top down, how bloody it would be. And this was
Yeah.
essentially bloodless. I would imagine the first stricture would have been just dripping, kind of oozing until it stops on its own. It would have been hard to see everything else.
It's so true. It's like doing ESD where you can see where the blood vessels are. But one of the things with needle knife is you're really not supposed to get into the submucosa. Once you see the submucosa, that's sort of typically where you stop, because you'll see this the scarring in the mucosal layer. And once you get through that, then you can see the exposed SM1 layer. And if you go deeper than that, then you'll see the blood.
Yeah.
But that's a good point with the balloon dilation. You just never know how deep you go in the submucosa. This is much more controlled.
Right.
Yep. So okay. So we've got the balloon up to 13.5. And what I'm going to do is I'm just going to kind of pull the balloon back and see if it gets caught on anything. And if it doesn't get caught on anything, I think that's a successful procedure. So G junction was okay. This is looking okay. And let's see if we can kind of get through the top. And it's much better. So I think, for me, oh, can you push wire? So for me, this is going to be I think this is going to translate into a very good clinical outcome for him. He's already made a lot of improvement with what we've done so far. I think this is going to be his best procedure yet. And so I think we're going to be in good shape. And
Right, fantastic. Great outcome, Jason. It looks super. And I think what we're gonna do now is take a 15-minute break. Oh dear. Yeah, there was a question for you, Jason, about savories. What about just the old fashioned, do a savory and go from there?
Actually, we were just talking about that. And I think the one good thing about savory is exactly how wide you've gone with that savory. It's certainly probably the least precise way of doing things, but if you do it in a stepwise fashion and you eventually get everything to this sort of level of mucosal tearing, I think it's okay. But again, I think here, because you're tearing at multiple locations and it's a very controlled depth of tear, I think we're probably going to see better outcomes, although there really hasn't been any data to say that savory is any worse than what we're doing here. And so I still use savory from time to time for sure.
Okay, sounds good. Well, we're going to switch over to before we take a break, or people need to. Ken Chang has one other thing he's going to show us. So if we can switch over to Ken, that would be great.
All right, Tom. Thanks very much.
Thanks, Jason. That was an excellent demonstration.
Tom, can you hear us?
We can hear you now. Yes.
All right, let me share the screen. All right. So we wanted to finish the TIF procedure. Let me put it on full screen here. Okay. So we're just going to continue where we left off. We put a single plication on the posterior side, and we're just going to continue. Okay. Visa some more. Yep. Okay. Roll out a little bit.
Oh, we're not hearing you too well, Ken.
Okay. Let me see. They're not hearing it too well.
And we're not seeing any movement on the video either.
Okay. Stop screen. Stop share. All right. I'm gonna re-share. Optimize. No optimize. Okay. All right. So we're gonna roll this way and play some more. Play. Can you hear okay?
Yes, we can hear and see now.
Okay. Okay, now you're going to re-insufflate, and you turn the valve on and push the air button. I'm going to roll out. I'm going to push off the diaphragm a little bit. Got it.
All right, two, suction off.
Okay, so now,
And if you're creating your omega valve here, the goal, I guess, one of the advantages of TIF is that it's tight, but maybe not too tight, and you avoid some of the sort of side effects of Nissens. Do you find, the 270 versus 300? What do what exactly are you shooting for when you're done here?
yeah, at least 270, and we've looked at studies more recently to see if there are parameters that will predict long-term better outcomes. And 270 and 300 degrees will predict a better outcome than 260, 250, 240. So the degree of wrap is important, but we're avoiding the 360 because 360 is not physiologic. With a 360 tightening, there's no real opportunity to vent because it's a constant, tightness. Where if it's 270 or 300 and it's long and it's floppy, then patients can still throw up, they can still belch and burp and dent, but acid trying to get up will close the flap valve. And there's nothing really surgically that can really mimic the kind of flap valve that we can create endoscopically, my opinion. I'm going to unlock the helix. A little bit too. Open the tissue mode, push that out again. Okay. Right, I'm ready for the third plication. Want to have you desufflate? Desufflate. Okay, that's good. Now rotate this way, you rotate the other way. Desufflate some more. Desufflate. Lock, touch not. Re-insufflate. I'm going to roll out. I'm going to push out the diaphragm. Fire.
Part 3, suction off.
Okay, on the clock.
11 o'clock.
Okay.
So I'm going to open the tissue mode. I'm going to push this helix forward. So now I've done my 3 plications and I'm removing the helix off of the tissue, and then I'm going to push the device into the patient so then I can freely rotate to the anterior corner. Again. Okay, now I'm going to rotate anterior, and as I do that, I'm going to create space for you. Not yet. Okay, I'll tell you when. Now there's space for you. Okay. All right, so I'm going to go to the anterior side. And so I'm back at 12 o'clock, and that's my helix. And I want to target just slightly below the Z line. So you can see the squamous epithelium, and you can see the helix rotating just at or below the Z line. That gives us a very, very strong hold. That tissue is quite robust. And you can see the balling up of the tissue. Now that means the anchor is solid. And now I'm going to roll out to free the retractor from the device. And once I rolled down, created space, now I'm going to set the device by pulling it back, pull, just like that. That's setting the device. And then now I'm going to pull on the retractor to bring the esophagus down and create the valve length. And here I'm about 3.5 centimeters. That's quite a bit of length that I can create. And now I'm max, so that's about 4 centimeters of length that I just created. And then with that length, since I'm on the anterior corner, I'm going to rotate counterclockwise towards 12 o'clock to create that wrap of bringing the stomach up and around. See, the stomach is going up and around the esophagus, and I'm tucking it back here, not full 360, but about 300 degrees this time. So once I'm there, I'm gonna lock, suck, and push off the diaphragm, lock the tissue, lock the helix, lock the tissue mold, turn on the suction, push the device down a little bit, and then fire. When I fire, I'm firing across the esophageal wall, across the gastric wall, and the fasteners leading leg fall into this little clear chamber. So that's the first bite. Okay. So now we relax everything, and we're gonna do the second bite now. So same thing, as I said, everything's kind of repeated itself. I've done my first plication. Now I'm going to set my device, pull the retractor, pull, pull, pull. And once I've maximally pulled, that's the length, then I'm going to wrap by rotating counterclockwise towards the 12 o'clock position. So here I'm just milking the tissue down further, and I'm getting maximal length, and I'm happy with that. And then I'm rotating towards 12 o'clock while Peter is suctioning to give me as loose a tissue as possible. And now I can close everything, lock, suck, push off the diaphragm. And look at the valve length there, Raman. It's just very nice. Yeah.
It's amazing.
Yeah. So, so now we've done our third bite. And so now, oh, here comes the third bite.
Ken, this is great. This is amazing. From a time check point of view, we're about to go on a break before they take away our food. Do you want to fast forward on your video just so we can see what it looks like at the end?
Okay, here we go. So here's fast forward. That's my third application. Now I'm coming to the greater curve, anchoring at 6 o'clock. And then I'm going to pull back, pull, and create great length. And then I'm going to take a bite here at 5 o'clock. I'm going to shift over to 6 o'clock, take a bite here at 6 o'clock, take a bite here at 7 o'clock, and at 8 o'clock. So 4 bites, 5, 6, 7, and 8, and that's it. That's my 10. And then I'm going to reload and just do some touch up. So the touch up, I'm doing one posterior reinforcement back there. I'm doing a mid valve posterior there. I'm doing anterior reinforcement there. And then I'm right in the middle, I'm putting a few mid valves, and that's it. So now I'm going to come out, and you can see how nice it looks from the inside here. This is looking at it, through the device. You can see that the fasteners are not sitting on each other. They're spaced very nicely apart and just sparing that lesser curve. And then now when we come out, you're going to see the endoscopic view. Now the scope is going through the, that's our new valve, Tom.
That's great.
4 centimeters in length, 300 degrees. And this patient did super well. No dysphagia, but essentially eliminated her GERD symptoms. So with that, I'll stop sharing. And
yeah, I think one of the great things about this technology, even though we're doing this, we all know how much reflex symptoms really complain of symptoms. I've been amazed at how few people contact me after this procedure, in that you don't just have a lot of the side effects you traditionally do with anti-reflux procedures. So it's really very well tolerated, and as obviously the right patient selection is very important. Hernia reduction is critical, I think, right, Ken? I think you'd agree, and that you really have to measure your Hill grade accurately. A lot of folks don't necessarily do that entirely rigorously, and so. But with 2 centimeters or less, it can be done as a straight endoscopic procedure. When it's more than that, I think Ken and colleagues and many others have shown that the hernia reduction is critical in order to get the best results.
Great. No, thanks. That was a fantastic case. I'm going to give you a round of applause for all those cases this session. And we're going to switch over, just take a 10-minute break or so, bio break, and get a little coffee before they take it out. Then we'll hear 3 more lectures and then another set of 3 live demonstrations. Thanks, everybody.